Namaste and good evening, everyone. A very warm welcome to Precision Oncology 2025 and beyond. We are delighted to have your esteemed presence for this two-day live webinar, where thoughts leaders and experts are sharing their invaluable insight into the evolving landscape of oncology. It is now my honor to invite our program convener, Dr. R.K. Chaudhary. He is a director and head, Department of Medical Oncology and Hemato-Oncology at Metro Hospital and Cancer Institute, Delhi, and Metro Multi-Specialist Hospital, Noida, to share his thoughts and setting the content. Dr. Chaudhary, it's over to you.
Thank you. Thank you so much, and very warm good evening to each and everyone. Thank you so much for joining, and thank you all our academic partners. Just I got a call. Sorry, I'm getting a continuous call. So good evening, everyone. It gives me an immense pleasure to welcome you all to today's academic program, Precision Oncology 2025 and beyond. Being organized under the aegis of Cancer Research and Strategic Foundation, as we step into the era where the cancer treatment is rapidly evolving, precision oncology stands at the forefront of innovation, from molecular diagnostic to targeted therapy to immuno-oncology and bispecific antibody. We are witnessing an exciting transformation that is redefining patient outcome. The purpose of this meeting is not just to share the knowledge, but to engage a meaningful discussion on how these advances can be translated into everyday clinical practice. Over the next couple of hours, we will cover critical updates in lung cancer and hematological malignancies, ranging from checkpoint inhibitors like tislelizumab, novel treatment strategies for ALK positive patients, and EGFR mutation positive non-small cell lung cancer, to new paradigms in myeloma and lymphoma care. I am really delighted to have with us an esteemed faculty of distinguished oncologists who will share their expertise and perspective. Their contribution will no doubt enrich our understanding and help us all in shaping the future direction of care in India and beyond. I sincerely thank each one of you for joining us this evening despite your busy schedule, and I encourage you to participate actively in the discussions. With that, let's begin today's scientific meeting. Thank you. Thank you so much.
Thank you, sir. Uh, Now I would like to invite first speaker of the day, Dr. Ankur Nandan Vasne. Sir is Senior Consultant, Department of Medical Oncology at Medanta, Gurugram. Sir will give his talk on exploring patients in and gastric cancer. It's over to you, sir.
Thank you, everyone. And thank you, Dr. Chaudhary. It's an honor to start the meeting. And we are starting with a newer molecule who have been recently launched, which is tislelizumab. And the advantage of this molecule is that it's far pretty cheaper than the conventional immunologic therapy which we are having, and this will give a huge beneficial to the Indian patients. So coming to the scientific discussion on tislelizumab potential in esophageal and gastric cancers. Next slide. Next slide. We need to move to the back to last slide. Okay, so definitely, I would like to say that tislelizumab is a newer molecule. The most specific thing is it binds to PTL L12 receptor, which is quite different from the mechanism of action through the conventional anti-PDL1 inhibitors like pembrolizumab and nivolumab acted. Now, this molecule has been approved in 12 approved indications, and 5 are under review. And majority of the key global trials had gained its approval in second-line treatment in esophageal squamous cell cancer, first-line treatment in esophageal squamous cell cancer, second and third line treatment in non-small cell cancer, first line treatment in gastric and gastric esophageal cancer, first line treatment in SCC, second line treatment in SCC, and it has also got approval in relapsed and refractory Hodgkin lymphoma as well as mature T and NK cell lymphoma. Majority of these are phase 3 studies, some are phase 2 studies, and the majority of approval have been given through European Union as well as a next slide. So, as I discussed, binding orientation as compared to the other PDL1 inhibitors, and this bind to this specific site, which is the unique binding epitope of this molecule, and this differs from the Pembro and Nivo, and the binding surface is of PDL overlapping to less complete of PD1 and PD1 access to more than 99%, while the conventional immunology therapy give a partial PDL1 blockade up to 80 to 81% only. So pharmacologically, it seems to be more beneficial as compared to the other drugs. Next slide. As we were discussing, this molecule is specifically engineered to bind F sites of macrophages, and now we study the clinical approval of these studies with clinical trials, which is one. The very first trial is the Rational 306, which had studied the combination of tislelizumab plus chemotherapy versus placebo plus chemotherapy for advanced or metastatic squamous cell cancer of esophagus in first line. Next slide. So this is a phase 3 randomized placebo control arm study where patients with unresectable, locally advanced and metastatic esophageal squamous cell cancer were included. No systemic treatment was allowed. And these patients were randomized either to receive tislelizumab 200 milligram every 3 weekly plus investigator chosen chemotherapy or placebo chosen. The endpoint of this study was overall survival, and secondary endpoint was PFS, ORR, DOR, and OS in PDL1 score. The baseline population was stratified into PDL1 score more than 10% or PDL1 score less than 10%. Next slide. So coming to the results, we see a very good median overall survival advantage with a combination of tislelizumab, which showed a median OS of 17.2 months versus 10.6 months shown with placebo plus chemotherapy. The hazard ratio was 0.66, quite impressive, and p-value was quite significant. If we see the 3 years over OS data, approximately 22% patients were surviving in the tislelizumab arm, and 14% patients were surviving in the chemotherapy arm. So the primary endpoint was classically met, and there was a 6.6 months of additional overall survival with 34% reduction in risk of death was met in patient population, which in this was irrespective of PDL1 expression. Next slide. So coming to key secondary endpoint, PFS, if we see the PFS in the tislelizumab cohort, it was 7.3 months. The median PFS in the placebo arm plus chemotherapy arm, it was 5.6 months. The overall response rate reported with tislelizumab with chemotherapy was 63%, while with placebo, it was 42%. If we see the responses defined, then complete response was reported in 15 patients, 4.6% of patient population, as compared to the chemotherapy, which was only 2.5. So we see almost there was doubling of complete response rate reported with the use of tislelizumab plus chemotherapy. Partial response was reported in 58% of patient population with the tislelizumab and in 39% patient population on chemotherapy. If the specific areas of interest, which was progressive disease, was documented in only 4% of patient population in tislelizumab with chemotherapy, while it was reported more than 3 times in 13% in patient population with chemotherapy with tislelizumab. Duration of response. So we see patients who was getting tislelizumab had better median duration of response, which was so tislelizumab showed a better tumor response, greater recovery, and these responses were more durable. Next slide. Coming to the rational 302 study, which includes the tislelizumab versus chemotherapy, single agent tislelizumab versus chemotherapy for advanced or metastatic squamous esophageal cancer in second line therapy. Next slide. So again, this is a phase 3 trial design in which patients with advanced metastatic esophageal cancers who have shown progression after first line systemic treatments were included, and these were randomized to either receive tislelizumab 200 milligram every 3 weekly or investigation chosen second line chemotherapy. Treatment was allowed until disease progression or intolerable side effects. Primary endpoint of this study was overall survival, and secondary endpoint was OS in with patients with CPS more than 10%, and other secondary endpoints was PFS, ORR, duration of response, and safety analysis. Coming to next slide. We see a significant OS advantage in second line with median overall survival reported to be 8.6 months versus 6.3 months. And if we see the patients with TPS more than 10%, this benefit is even greater with median overall survival 10.3 months versus 6.8 months. So there was a 30% reduction in risk of death with additional 2.3 months OS in the general population, and there was 46% reduction in risk of death and 3.5 months additional OS reported in patient population with CPS score more than 10%. So there is a significant overall survival in all randomized patients, and this survival is specifically statistically significant in patient population with CPS score of more than 10%. Next slide. Coming to see key secondary endpoints, we see a PFS advantage reported was far better than chemotherapy. PFS advantage given with tislelizumab was better numerically, and these curves began to separate 3 months after randomization in favor of tislelizumab. We see the overall response rate. They were approximately 52% in patient population with receiving tislelizumab, while it was only 25% in patient receiving chemotherapy. And duration of response was 7 months versus 4 months. So tislelizumab was associated with a greater overall response rate and more durable tumor response rather than chemotherapy. Next slide. So comparison between the other clinical trials going on, and we see the ratio 306, the median overall survival reported was 17.2 months versus 10.6. In Keynote, the median overall survival benefit was 12.6 months versus 9.8 months. With the Checkmate study, the median overall survival was 13.2 months versus 10.7 months. So if we see the cross trial comparison is not generally considered, but numerical advantage is provided with the use of tislelizumab over other immunotherapies. And if we see the difference in OS is as similar in the PFS, where 7.3 months PFS benefit was there as compared to the 6.3 and 5.8 in other clinical trials. Next slide. So moving from esophageal cancer to the gastric and gastroesophageal junction cancers. Next slide. Coming to rational 305 study, studying tislelizumab plus chemotherapy versus placebo with chemotherapy for advanced metastatic gastroesophageal adenocarcinoma in first line. Next slide. So this is again a phase 3 randomized placebo-controlled trial where patients with a histological confirmed gastric cancer or gastric junction adenocarcinoma, HER2 negative disease was taken. Prior treatment was not allowed, and these patients were randomized to receive capox or cisplatin with 5FU along with tislelizumab versus placebo plus chemotherapy. Treatment was continued until acceptable toxicity and disease progression. The primary endpoint of this study was the overall survival, and secondary endpoint was PFS, overall response rate, duration of response. Stratification was done with PDL score, PDL more than 5% versus less than 5%. Next slide. So coming to the OS benefit, with the use of tislelizumab, median overall survival was reported to be 15 months, while with the placebo plus chemotherapy, this was 12.9 months. This is a hazard ratio of 0.8, and the p-value was found to be significant, 0.001. And if we look at the Kaplan-Meier curve, there's quite separation after 1 year when the chemotherapy stops functioning, and this separation is continued at the end of 2 weeks. Approximately 32% of patients in the tislelizumab cohort were surviving, while only 23% patients in the chemotherapy arm were surviving. Next slide. Looking at the PFS, numerical advantage is provided with the use of tislelizumab. The PFS was reported 6.9 months. With the placebo, it was only 6.2 months. Overall response rate was better with the tislelizumab. It was 47.3 months overall response rate, while it was 40% with chemotherapy arm. Coming to duration of response, it was 8.6 months versus 7.2 months. So tislelizumab plus chemotherapy is showing a numerical advantage in PFS, overall response rate, and the responses are more durable. Next slide. So coming for a cross-trial comparison between various immunotherapies. So tislelizumab has shown a OS benefit of 15.4 versus 12.8 months. Amrolizumab has shown advantage of 15.7 months versus 11.8 months, and nivolumab has shown a advantage of 14.4 months versus 11.4 months. And the main criteria of difference is in keynote study, the stratification was for more than 10%, while in other trials, it was only 5%. So tislelizumab has shown a better numerical advantage as compared to the other drugs. Next slide.
Sir, request you to conclude your presentation in a
Yeah,
minute.
okay. So tislelizumab plus chemotherapy demonstrate a significant clinically improvement in overall survival and disease control in patients with first line esophageal squamous cell cancer. In second line esophageal squamous cell cancer, again tislelizumab has shown a significant and meaningful improvement in survival as well as tumor response as compared to the single agent chemotherapy. In first line gastric esophageal cancers, tislelizumab plus chemotherapy has shown us again a meaningful improvement in overall survival, disease control, and response rate as compared to the chemotherapy alone. Thank you. So these are the other recommendations with tislelizumab.
Is there any question? If no question, we will move forward. For the next session is sponsored by Pfizer. For this, I would like to invite Dr. K.M. Parthasarthi, Sir is Director and Senior Consultant, Department of Medical Oncology at Dharamshila Narayani Super Specialist Hospital, Delhi. It's over to you, sir.
Yeah, have you got the slide sets?
Yes, sir. We will share.
Okay, please share it. I got 15 minutes. How much is the time duration?
So 10 minutes.
Okay, okay. So I'll just brush through the things. Yeah, the topic allotted to me is ALK ODC, diagnosis to innovation. Next slide. Yeah, we know that there are so many mutations which are targetable. ALK constitutes around 4 to 8% of the patients. Next slide, please. The ALK mutation is detected by many modalities. We are doing IHC, FISH, and RT-PCR. Among these, FISH is somehow is obsolete these days. IHC is cost effective, but false negatives can be seen. RT-PCR is the most sensitive method, but it is time consuming and it is costly. Next slide, please. Next slide. Yeah, this is the evolution of ALK agents. The first generation ALK is crizotinib followed by ceritinib, then alectinib, brigatinib, second generation, and the third generation lorlatinib. Lorlatinib has been approved as first line from 2021 onwards. It has got a great penetration into CNS. Next slide, please. So, the ALK positive lung cancers are generally young patients, non-smokers or light smokers. Around 20 to 40% of the patients have CNS mets at presentation. So the agent we should select should have a good CNS penetration. That is the idea of lorlatinib, which has got a very good CNS penetration. Next slide. So why we are using our most active agent in the first line is that 25% of the patients will never get the chance of getting a second line treatment. The most active agent should be used in the first line. Next slide. So 20% of the patient will go on to develop brain metastasis with the second generation TKI. The agent we are using should have a good CNS penetration. Next slide, please. Yes. So these are the qualities of using an ideal ALK agent. It should have a good response rate, good overall survival, good PFS, manageable toxicity, and should increase the overall survival. Next slide, please. This is the crown study. Everybody knows uh, inoperable stage 3 and stage 4 patients upfront, asymptomatic or untreated CNS metastases were permitted. They were randomized in a 1:1 fashion to lorlatinib in the standard dose of 100 milligram per day versus the first generation TKI crizotinib 250 milligram twice a day. The PFS is the primary endpoint. OS and response rate, duration of response, intracranial time to progression were the secondary endpoints. Next slide, please. So in the crown study, we have seen that the median PFS, we'll come to that, the updated PFS. The investigator assessed median PFS at the time of publication was 36.7. And the LX study, it was 34.8. And the brigatinib study, it was 30.8. Next slide, please. So we are today presenting the updated 5-year OS. Next slide. So we have seen that at the end of 5 years, that is 60 months, the reported PFS is 60%. That is 52% of the patients are at the end of 5 years are progression free, which is unprecedented in any lung cancer studies. The comparator arm of crizotinib was the PFS was only 9.1 months. The response rate with Lorla is 81%, and the complete response was seen in 15% of the patients. Next slide, please. So this is what we are talking about. The median PFS was not reached, but then at the end of 5 years, it is crossing. It is crossing 60%, and the graph is getting a flat visual representation. So they are getting a kind of flat graph, which is showing that most of the patients are continuing progression free, and the OS is still not achieved. Next slide. So almost whether they are brain mets or not, they are continuing to respond. And you can see that smoking or non-smoker, every subset is having a good hazard ratio. Next slide. So this is the rule of two. It's a very interesting slide, which is showing that the second generation ALK inhibitors, they have doubled the PFS, double the hazard ratio. That is, the hazard ratio is 0.5. Again, the third versus first, the hazard ratio is 0.18, 0.19. That means it is it has doubled the compared to the second generation. So every generation you are getting the hazard ratio is getting halved. Next slide. Here the you are comparing with the alectinib. The 4-year OS of Alex in the Alex study is 65%, but in the case of Lorla, even the PFS is more than 60% at the end of 4 years. Next slide. So the overall survival is not reached in the Lorla study, but in the Alex study, it is 5-year OS is 62.5%. In the updated OS is going to be present in the next ESMO, in the next ESMO. And in the brigatinib study, the Alta one, the 4-year OS is 66%. Next slide. Next slide. This we have already discussed. Next slide. The intracranial progression is also 92% of the patients are not progressing. Next slide. Here, whether without baseline metastasis or with baseline metastasis, the graph is almost the same. That means whether the patient have got an upfront brain metastasis, it doesn't matter. The progression-free survival is almost the same. Next slide. Here, the updated overall intracranial response. The complete intracranial response is 58.3%. In the Alex study, it is only 38%. Next slide. Subgroup, next slide. This slide is showing that the unfavorable subtypes like variant 1 and variant 3B, it has gotten a very impressive PFS in the lorlatinib. So when we are using lorlatinib, the variant 1 and 3AB doesn't matter. Next slide. Safety and therapy. Next slide. This discontinuation is very less in the Lorla study. The permanent discontinuation was seen only in 5% of the patients, that too in the first 26 months. Next slide. Next slide. These are the common side effects. I am not going to the details because of the time constraints. Next slide. But this is a very interesting slide. we can see that the hyperlipidemia is a very early event, but at the same cognitive side effects and speech and psychotic side effects are somewhat late side effects, and the peripheral neuropathy and weight gain. Weight gain is a late side effect which is seen after 100 days. Next slide. So this hyperlipidemia, you have to use an, uh, anti-cholesterol drugs, and the weight gain, you should ask the patient to control the diet and improve the physical activity. And the CNS side effects, in the mild side effects, you are not reducing the dose. Next slide, please. These are the CNS side effects: cognitive side effects, mood side effects, speech and psychotic effects. The schizophrenia-like side effects are seen in very less. Grade 3 and grade 4 are only 1% each. Next slide. These are the psychotic side effects are seen in 3%, and the grade 3 and grade 4 are 1% each. Next slide. Most CNS adverse effects did not require medical intervention. Next slide. So this is the side effect management. Everybody knows. We are using rosuvastatin at a dose of 10 milligram orally once a day, and uh, and then you are monitoring the lipids. Next slide. This is everybody knows the weight gain, lifestyle modification, toxicity management, edema, again lifestyle modification, therapeutic intervention, and CNS. If mild CNS toxicity, you are not interrupting the drug. Probably you can give a brief interruption, and in severely bothersome, then you have to stop the drug. Next slide. This I'm not going to detail because of the time. Next slide. So this is an Indian study which is showing that the toxicity efficacy are more or less in the as per the Crown study. Next slide. This is a pedal edema, that is 18.4, mood side effects, 2 patients, intracranial objective response rate 70%, complete intracranial response rate around 21%. It shows that the real world study of Indian patients is more or less as are consistent with the data from the Crown trial. Next slide. So this is the last 1 or 2 slides. We have seen that upfront lorlatinib is showing the maximum OS and maximum PFS. The PFS at the end of 5 years is 60%. So OS is still not reached. So the idea is to use your best friend upfront. Next slide. So that is the data with lorlatinib. Updated PFS we have presented. So the toxicity management are very much manageable drug. The permanent discontinuation is only 5%. Thanks for listening. Any question, I'll be happy to answer.
There is any question? If no question, there is little bit change in schedule. Next session will be sponsored by Roche. For this, I would like to invite Dr. Nitin HG. Sir is consultant, Department of Medical Oncology at Fortis Hospital, Vasant Kunj. It's over to you, sir.
Hi, good evening, all. Am I audible?
Yes, sir, audible.
And the slides are moving, right?
Yes, sir.
Okay. Good evening, all. So this is becoming a major academic feast today with a lot of discussions pertaining to major updates in oncology. And thank you, Dr. Chaudhary, for inviting me for your this wonderful session. And thank you, Roch, for giving me this opportunity. So I'll start off with redefining the management of non-small cell lung carcinoma with atezolizumab now and next. So we all know that non-small cell lung carcinoma treatment paradigm have totally shifted from basically chemotherapy towards more of targeted therapy and immunotherapy based treatment. And the outcomes of non-small cell lung carcinoma in last 1 decade have improved markedly with in advancements in all these treatment options, including whether it be immunotherapy or targeted therapies. So I'll be mainly concentrating on the role of atezolizumab and how that has changed the treatment paradigm of lung cancer, especially non-small cell lung carcinoma, and its role mainly in metastatic setting. As we all know, nowadays, earlier the immunotherapy and targeted therapy has been incorporated into treatment of metastatic and stage 4 disease. But recently they have moved towards and they have not got incorporated in treatment of early stage lung cancer as well with very good results. So we have atezolizumab data in adjuvant setting for early stage lung cancer also. And even for perioperative setting also, we have upcoming data with atezolizumab. But I'll be just concentrating mainly on metastatic setting where the path-breaking trial, IMpower 150, brought about a combination of atezolizumab, bevacizumab, and chemotherapy for treatment of advanced non-squamous non-small cell lung carcinoma. So, as we all know, treatment options for lung cancer, earlier it was the first treatment option was chemotherapy, but right now we either go for a combination of chemoimmunotherapy or chemoimmunotherapy for anti-VEGF inhibitors, or if no driver mutations, if finance is a major issue, then we actually resort to a chemotherapy based regimen alone. But in general, most of the patients get the opportunity to have a combination of immunotherapy or anti-angiogenic drugs or a targeted therapy. So the whole treatment basically depends on whether there is a targetable mutation or not. So if there is an untargetable mutation, as we all know, accordingly we'll be giving some targetable therapy in the front line. But if there are no actionable driver alteration, then our treatment option becomes restricted to more of chemo immunotherapy combinations or immunotherapy, single agent immunotherapy if the PDL1 or TCIC score very high, or chemotherapy if none of this falls into the criteria. So if the patient has received immunotherapy in the first line setting and they have progressed, in the second line setting, we'll be going for chemotherapy alone or in combination of anti-angiogenic factors. On the other hand, if we have not received first line immunotherapy, then we'll go for immunotherapy in second line as well. So atezolizumab got its approval first. It was approved in second line of metastatic non-small cell lung carcinoma based on the OAK trial, which was an approval came in 2016 and in India in 2017. But in first line, the major change happened when it has got introduced in the treatment armamentarium of first line of metastatic non-small cell lung carcinoma based on the path-breaking IMpower 150 trial. And the approval came in 2019 by the Indian agencies and 2018 worldwide. So right now we are using atezolizumab in front line for treatment of metastatic non-small cell carcinoma. And recently, based on the data of IMpower 010, we also have started using atezolizumab in adjuvant setting in early stage non-small cell lung carcinoma. So briefly going into various trials that have led to the approval of atezolizumab in metastatic non-small cell lung carcinoma. There were mainly 3 phase 3 studies that led to this approval in frontline setting of non-small cell lung carcinoma. The first one was IMpower 110, the second one IMpower 130, and the third one IMpower 150. So IMpower 110 mainly compared immunotherapy as compared to chemotherapy combination. And it was mainly in irrespective of whether it was squamous or non-squamous, it was used in all non-small cell lung carcinoma subsets, and it was predominantly, the results were predominantly in favor of those patients who had a higher PDL1 score. IMpower 130 actually came up as a trial to prevent use of steroids, especially in patients who are diabetic or who have got poor sugar control, as well as to avoid the side effects associated with using steroids, especially in combination with immunotherapy. So in this setting, we use atezolizumab plus a combination of carboplatin, and the paclitaxel was replaced by nab-paclitaxel versus a combination of carboplatin and nab-paclitaxel. IMpower 150 was a major trial that led to all of us, I mean, especially our clinicians, to mainly use atezolizumab in frontline setting in lung carcinoma. It was a 3-arm trial, which has got an arm A with atezolizumab and chemotherapy, arm B with atezolizumab, bevacizumab and chemotherapy, and arm C with chemotherapy and bevacizumab. So first of all, IMpower 110, it was done in a PDL1 selected patients, first line non-small cell lung carcinoma. As I told, there were 2 arms. One was atezolizumab 1200 milligram Q3 weekly, and the comparator arm was in non-squamous we use carboplatin or cisplatin plus pemetrexed. Well, squamous it was carboplatin plus cisplatin or gemcitabine. 4 to 6 cycles followed by atezolizumab. It was atezolizumab maintenance. On the other hand, in non-squamous, even though patient have received cisplatin or carboplatin or paclitaxel or gemcitabine in the first line setting, the switch maintenance was allowed with pemetrexed in the maintenance phase. And they were all of them were EGFR and ALK negative, and they were substratified on the basis of various histology PDL1 expression. So the catching point is that for atezolizumab, the PDL1 testing was mainly done by Ventana SP142 IHC assay. And here we use the score, unlike PDL1 CPS or TPS, the score that was used was TCIC. TC is tumor cells which are stain positive, and IC is immune cells stain positive. And they were divided 1 to 3 based on the percentage of staining. So TC 3 means more than 50% of staining, while IC 3 means more than 10% cells which are staining. And vice versa, TC 1 means less than 5%, IC1 was less than 5% staining in immune cells and tumor cells respectively. So primary endpoint was overall survival, and they mainly found that in the subgroups which were having a PD-L1 expression of TC1 or 2, their data was relatively not consistent. On the other hand, TC3, IC3 expression had got a very good response. So this is a Kaplan-Meier curve showing the overall survival of TC3, IC3 subgroup. And as we can see from the curve itself, there was markedly, initially they were very close, but there was a early separation followed by a maintained separation throughout the course. So 6-month overall survival in the arm A was 76.3 versus 70.1, while 12-month OS was 64.9 versus 50.6, and hazard ratio of 0.59, which was statistically significant. So median OS was 13.1 versus 20.2. There was almost 7 months of benefit in atezolizumab arm, single agent atezolizumab arm in TC3 IC3 subset. So this was an updated analysis of TC3 IC3 subset, especially for the PFS, as compared to chemotherapy. In comparison to OS, the results were consistent. As we can see that in PFS, there was around 3.2 months of PFS benefits in addition of on using atezolizumab as a single agent in TC3 IC3 subset. So this was the objective response rate, as especially again TC3 IC3 group. As we can see that in arm A, where atezolizumab was used, the overall objective response rate was 40% as compared to 28.6% in those patients who received chemotherapy alone. And the duration of response, that was markedly increased. That was almost in the range of 3 years, 38.9 months versus 8.3 months alone in chemotherapy arm. So overall survival benefit in PDL1 high. So this was again compared later with other PDL1 staining platforms like SC22C3 and SP263. So all the subset of SP142 who had TC3, IC3, that is very high PDL1 expression, and had got a very good survival on OS and PFS, were the same subgroup has also been compared after staining in with 22C3 and SP263. And we can see that from the curves, we can see that the curves were almost consistent, and all the results were also consistent with the separation of both the curves in all the 3 staining platforms. So it was found that TC3, IC3, SP142 in atezolizumab was consistent with TPS more than 50% of 22C3 and TC more than 50% of SP263. And median OS, as we can see, is almost similar in the atezolizumab arm in all the 3 platforms of around 20 months. So the safety analysis was again consistent with the data from the primary analysis. And as compared with chemotherapy, the immunotherapy arm also fared good. And the side effects was mainly immunotherapy mediated side effects. Grade 3, 4 side effect was relatively very less as compared to chemotherapy arm, 33 versus 53%. And serious treatment related adverse effects were also consistent in both the groups. And adverse effect mediated withdrawal. So because of the adverse effect, the number of patients who had to get withdrawn from the trial, that was only 7% in atezolizumab arm versus 17% in chemotherapy arm. So all cause adverse effects in patients on comparing between the two arms, as we can see from the plot itself, that all those patients who received atezolizumab had very less adverse effects, including anemia, nausea, neutropenia was too less. On the other hand, in chemotherapy arm, it's as expected. It was much high in the chemotherapy arm. But pruritus and some hypothyroidism and other immune-mediated adverse effects were more common in the arm A, which was atezolizumab arm. So IMpower 110 summary is it was a positive study, demonstrated statistically significant and clinically meaningful improvement of overall survival in TC3 and IC3 wild type population and versus platinum-based chemotherapy with a hazard ratio of 0.59. And it was consistent. The results were consistent with PFS, objective response rate, and duration of response. And safety profile was also consistent with the primary analysis. So then came the second trial, IMpower 130, especially non-squamous non-small cell lung carcinoma, where they compared nab-paclitaxel, a combination of nab-paclitaxel and carboplatin in combination with atezolizumab versus combination of carboplatin and nab-paclitaxel as the comparator arm. Here again, 4 to 6 cycles were given, followed by atezolizumab maintenance. And as I told earlier, here also, a switch maintenance with pemetrexed was allowed because paclitaxel carboplatin to have a maintenance was difficult, and hence the patient were allowed to use pemetrexed or a best supportive care if on progression or as a maintenance as well. So switch maintenance to pemetrexed was permitted in the control arm. And in atezolizumab group, we use atezolizumab 1200 milligram plus carboplatin AUC6 and nab-paclitaxel 100 milligram per meter square, day 1, 8, and day 15. Substratification was done basis of PD-L1 IHC expression and also bulk of the disease, especially liver metastasis. So primary endpoint was PFS, and secondary endpoints included PFS OS in intention to treat population as well as PD-L1 expression. So this is a diagram that shows how immunotherapy acts in cancer cells and how that chemotherapy addition to an immunotherapy. So chemotherapy, a backbone given along with immunotherapy, will help in increasing the immunogenicity and increasing the response of immune cells. So as we can begin from here, so there's a tumor microenvironment as we can see. So when you give chemotherapy, there will be death of a lot of tumor cells. So the death of the tumor cells or destruction of the tumor cells will lead to release of cell antigens. So these cell antigens, the cancer antigen will get presented to the T cells. So when the PD-L1 expression, normally there is a PD-L1 expression, and PD-L1 will lead to what do you call that? The priming of T cells on expression of neoantigens are subsettled by a PD-L1 receptor that is being expressed by the tumor cells. So when a PD-L1 is being blocked by a PD-L1 inhibitor, this lead to an excessive priming of T cells to do these neoantigens that are expressed by the death of cancer cells. So this will lead to priming and activation. This will lead to more trafficking of T cells to the tumor, infiltration of T cells into the tumor cells, recognition of the cancer cells, and lead to a killing of cancer cell. So PD-L1 expression leads to inhibition of anti-cancer T cell activity in the tumor microenvironment. So that's why we always decide whether immunotherapy will work or not based on this PD-L1 expression. Whatever score we use, TPS, CPS, TC, IC, ultimately one of the major point is that if the PD-L1 expression is high, then the chance of getting a better response with immunotherapy is much more. So invigorating tumor-specific T cell immunity through PD-L1 inhibition may result in deeper and more durable responses versus chemotherapy alone. So rationale for combining nab-paclitaxel, as I told earlier, nab-paclitaxel has got a cremapher-EL solvent, which can lead to increased hypersensitivity reaction, because of which we always have to give some pre-medication with steroids to prevent that hypersensitivity reaction. So steroids can actually decrease the response, T cell response or immune response, and hence can decrease activity of immunotherapy. So to avoid that, a nab-paclitaxel based chemotherapy backbone was used, where it was solvent-free, and hence the chance of of getting a hypersensitivity reaction was low, and we can omit dexamethasone or a steroid in the pre-medication. So in IMpower 130, these are the results from the IMpower 130. As we can see from the Kaplan-Meier curve, the PFS data is very consistent with marked separation of both the curves throughout the course of treatment, and the PFS was median follow-up of 18.5 months. The median PFS was 5.5 versus 7 months. So there was almost 1.5 months improvement of PFS in patients who received atezolizumab in addition to chemotherapy with a hazard ratio of 0.64, which was statistically significant. So this was a subgroup analysis of PFS benefit in intention to treat population. As we can see that those patients who had got TCI3, that is PDL1 high, those patients who had PDL1 low, that is TC1, 2, IC1, 2, also had a very good PFS benefit. This forest plot shows that it has got benefit favoring the use of atezolizumab in this subset, even though the PDL1 was negative, even though the study was not powered for looking for the substratification exactly. But from the forest plot, we can see that there was benefit in all the subsets of PDL1 expression, as well as in those patients who had liver metastasis or no liver metastasis. So IMpower 130, the OS was significantly, the OS also had a benefit, and there was around 5 months of benefits in patients who received atezolizumab versus chemotherapy alone arm in overall survival on a follow-up of around 18.5 to around 20 months with a hazard ratio of 0.79, which was statistically significant. So this is a subgroup analysis for OS benefit, but here the data was a bit confusing since PDL1, TC3, IC3, PDL1 low, TC3, IC2, all these cases in forest plot, we can see that the specific subgroup value was actually crossing the unity line with the confidence interval crossing 1. So as you can see from the OS also, hazard ratio was 0.79 and the confidence interval was almost reaching 0.98. So PFS benefit was consistently seen in all the subgroups, but OS benefit was not seen in specific subgroups, even though the overall population had got benefit. So IMpower 30, objective response rate and duration of response were improved with addition of atezolizumab to chemotherapy. So as we can see from the chart, the patients with objective response, there was 49%, almost 50% response rate in patient who received immunotherapy, atezolizumab over the patient who received chemotherapy alone. And median duration of response was 8.4 versus 6.1 months. And around 36.8% of patients had ongoing response even at the data cutoff time. So the IMpower 130 summary met its co-primary PFS and OS endpoints and demonstrated statistically significant and clinically meaningful benefit of 4.7 months in overall survival and 1.5 months in PFS for atezo plus chemotherapy in the intention to treat population. OS and PFS benefits are observed across all PDL1 subgroups, and atezolizumab plus chemotherapy had a safety profile consistent with adverse effect associated with single agent therapy. So I'm not sure about the OS benefit because OS benefit was again, it was crossing the unity line, but still the overall population, the benefit was significant, even though subgroup did not fare well. Now, the next trial, which actually led to the introduction of atezolizumab in treatment in our clinics. This was IMpower 150 non-squamous non-small cell lung carcinoma phase 3 study. Here the patient had got here there was 3 substratification. It was mainly done in non-squamous non-small cell lung carcinoma who were chemotherapy naive and irrespective. So when we consider all the immunotherapy trials, when consider other immunotherapy agents as well as the previous trials, in most of the trials the driver mutation EGFR and ALK positive cancers, those who are driver mutation positive has been excluded. But in IMpower 150, even there were a small subset of population who had got EGFR and ALK positivity as well. So tumor tissue available for biomarker testing for any PD-L1 IHC status. So there were 3 arms. Arm A was atezolizumab plus chemotherapy. Arm B was atezolizumab, bevacizumab plus chemotherapy. And arm C was bevacizumab plus chemotherapy. And the respective agent was continued for maintenance, stopping chemotherapy, and this was continued till progression. And the primary endpoint was PFS in intention to treat population as well as overall survival.
Dr.
So
Nitin, sorry to
baseline
interrupt
characteristic
you.
We are running short of
Yes.
time. Please conclude your talk in next one.
Okay. So as you can see from the from this distribution, the baseline characteristics were consistent amongst the groups. So the overall survival in the intention to treat population, median survival was for 19.5 month versus 14.2 in the comparator arm. There was a marked benefit with hazard ratio of 0.80 as compared to ABCP with BCP. And objective response rate, as you can see from the curve, that objective response rate as well as duration of response was also much higher in an ABCP group as compared to a BCP group. And the objective response rate was consistent in PDL1 high TC3 IC3 group, PDL1 low TC12 IC12, as well as PDL1 negative subgroups. So OS benefit was seen across all PDL1 subgroups. In PDL1 high, you can see that the curve was markedly separating with an OS benefit of 15 months in PDL1 high subgroup. In PDL1 positive, that is 1, 2, 3, all, when you take all the groups, again, the benefit were consistent with around 6 months of OS benefit. And in PDL1 negative also, that was a striking point in this trial. There was almost around 3 months of OS benefit between ABCP and BCP in even PDL1 negative subgroup. So when we consider the other key subgroups like EGFR mutated and ALK mutated, so of the whole population, around 78 patients had got a sensitizing EGFR mutation, and most of them were have received prior TKI therapy. So those who have progressed on EGFR TKIs, as we can see from this study, that even though the number was very less, those patients who have progressed on EGFR TKI also had got a benefit with ABCP as compared to BCP, with an overall survival benefit of almost 3 months with a hazard ratio of 0.59. And OS benefit in sensitizing EGFR mutations, again, arm B versus arm C, you can see that the benefit was there. Almost around 10 months of benefit was there with hazard ratio 0.6. And then other arm and other, as you compare arm A and C, there was no benefit. That means the benefit was mainly attributed by introduction of immunotherapy atezolizumab to this group. Objective response rate and duration of response also improved in bevacizumab ABCP group in EGFR mutated non-small cell lung carcinoma with a CR rate of around 6% in this population. Other subgroups were liver metastatic subgroup, that is bulky disease subgroups. In those patients also, this is a curve showing ABCP versus BCP in those patients who received liver metastasis, and they have clinically meaningful survival benefit in IM power 150 regimen despite liver metastatic being a negative prognostic factor in non-small cell lung carcinoma. So again, this is another curve showing between arm B and arm C, there was again survival benefit with a hazard ratio of 0.68, while between arm A and arm C, the liver metastasis did not show benefit. So liver metastasis is usually considered as a poor prognostic marker in non-small cell lung carcinoma, but those patients who received atezolizumab based therapy had got a marked improvement in survival, even in those patients with liver metastasis, and an objective response rate of 60% as compared to 40% with the chemotherapy arm. Bulky disease, they also substratified on the basis of bulky disease. I'm not going to detail of that. So they divided on the basis of size of the tumors, and we can see that the response was much higher in the population who received atezolizumab, especially in bulky disease as well. And this is a safety profile, as we all know that the side effect was bit more in the ABCP arm. Obviously, there were 4 drugs, and as expected, it was higher. But majority of patients fared well, and most of the side effects were pertaining to rash and other immunotherapy-based, immunogenic activation-based adverse events. So to coming to the summary, IM power 110 atezolizumab monotherapy in both the subgroups, squamous, non-squamous, PDL1 high expression had got improvement with single agent atezolizumab. IM power 130, yes, it had advantage with addition of nab-paclitaxel, but I don't consider it as very significant. But IM power 150 is definitely one of a path-breaking trial where ABCP combination improved survival not only just in PDL1 high group, also in PDL1 low group, and those population who have progressed on EGFR TKIs or ALK TKI and with bulky disease and liver metastasis. So that's all. If you have any other questions, I can take that. Hello.
Thank you, sir. Is there
Yeah,
any
thank
question?
you.
If no question, for the next session is sponsored by AstraZeneca. For next session, I would like to invite Dr. K.M. Parthasarthi sir again.
Yeah, have you got the slide sets?
Yes, sir. We will share. It's over to you.
Yeah, the topic given to me is monotherapy versus combination therapy in advanced EGFR mutated NSCLC. Next slide, please. So we all know that the burden of EGFR mutated NSCLC and the evolving armamentarium, the risk factors and poor prognostic factors, challenges in progression with monotherapy. And today we are going to discuss the mono versus combination. Next slide. EGFR mutated patients are seen in more in Asian population, around 40% of the cases, compared to the Western population, it's around 20%. And in the Indian population, it's around 33 to 39%. And these mutations are located in the tyrosine kinase domain and result in increased kinase activity of EGFR, leading to continued cell proliferation. The most common EGFR mutations are exon 19 and exon 21, L858R mutations. But other rare mutations are seen in exon 12, exon 18, exon 20 is altogether another subset that needs further discussion. So today we will be discussing more on exon 19 and exon 21. Next slide, please. So these are the first, second, third, and third generation TKIs. Geftinib and erlotinib are the first generation. Afatinib and Daco are the second generation, and the osimertinib is the third generation TKI. And as we can see from the bar chart, that the PFS is continuously improving from 9.5 in the IPAS study from over the years to 18.9 months in the FLORA study. Next slide, please. So how this mechanism, what is the pharmacological basis of combining chemotherapy with the TKI? If you are adding chemotherapy with the TKI, it acts synergistically by inducing apoptosis and suppressing the downstream pathways, that is AKT and previous slide, please. One slide back. Excuse me. Yeah. Suppressing the AKT and extracellular signal regulated kinase phosphorylation, and it thereby delaying the resistance. Oral TKI decreases the thymidylate synthase level, and it increases the pemetrexed efficacy as well. So they are mutually synergistic combinations. Next slide. So here what we have seen is that these combination studies, when you are combining geftinib with a carbopemetrexed, in the Japanese study, there is an improvement in the overall survival, and other studies were also shown numerically improved OS. Next slide, please. So this is the FLORA 2 study design. It is exactly like the FLORA 1, pathologically confirmed non-squamous NSCLC, exon 19 deletion and L858R patients. Stable CNS metastasis were allowed, and they are randomized in a 1:1 fashion. Osimertinib with the carbopemetrexed in the standard doses, or if you are using cisplatin, it's in the 75 milligram per meter square, 4 cycles followed by maintenance with the osimertinib and pemetrexed. The pemetrexed maintenance is exactly like the previous study, and osimertinib is maintained a daily dose of 80 milligram OD. And in the comparator arm, it is osimertinib alone. So the primary endpoint is PFS, and the Secondary endpoints are OS, overall response rate, and duration of response, disease control, quality of life, etc. Next slide, please. So these arms are evenly matched. You can see that adenocarcinoma constitutes around 99%, adenosquamous 1%, others 1%. The CNS metastasis again 40 percentage in each arm roughly. So next slide. You can see from this slide the PFS as per the investigator is very much improved. In the OC plus chemo, it is 25.5 months. In the monotherapy, it is 16.7 months. So the median PFS is improved by 8.8 months with the addition of chemotherapy. You can see that at the end of 3 months, the graphs are getting separated. At the end of 1 year, 80 percentage and 66 percentage PFS respectively. At the end of 2 years, 57 percentage versus 41 percentage respectively in the combination versus monotherapy arms. Next slide, please. So this is the BICR progression-free survival. It is again the graphs are almost the same. The combination is 29.4 months versus monotherapy 19.9 months. And the next slide, please. Here you can see that these L858R and the exon 19 arm, the hazard ratio is more or less equal. You can Flora 1, you can see that L858R was not faring that well with the monotherapy. So if you are adding chemotherapy, that is nullified. Both the mutations are faring well. And in the CNS patients also, CNS positive patients also, this combination is working very well. Next slide, please. Here, that is what we were explaining in the last slide. With CNS metastasis, the combination is 24.9 months. With monotherapy, it is only 13.8 months. Without CNS metastasis, probably the monotherapy is also an acceptable option. Here, the PFS is impressive, but with CNS, it is strikingly impressive. Without CNS, it is 27.6 months, 27.6 months versus 21 months in the monotherapy. Next slide, please. So, the PFS as per the investigator, the exon 19, you can see that 27.9 months versus 19.4 months. In the L858R, you can see that it is again impressive compared to the Flora 1. Here you can see that 24.7 months versus 13.9 months. So the patient with the CNS metastasis has got a median PFS of 24.9 months. Next slide, please. So the OS again, it is the graphs are separated, but the mature OS is not reached in the combination. In the monotherapy, you can see that it is almost at par as the Flora 1 study, that is 36.7 months. So here at the end of 3 years, the OS with combination is 64 percentage and 50 percentage in the monotherapy arm. The mature OS is not reached in the Flora 2. Next slide, please. So the resistant mechanisms are more or less the same. So the treatment with combination did not affect the resistant mechanism, and it remained similar across flora 1 and flora 2. You can see that the C797S, that is the commonest mutation on osimetric progression, that is 7% in the combination and 9% in the monotherapy. And PIK3 mutation, RTK amplification, more or less the same. And the RB1 loss is not reported in the monotherapy by 5% in the combination. Next slide, please. The safety, you can see, we can see that it is slightly more toxic because of the chemotherapy. Grade 3 or 4 events are 64% in the combination arm, and there are 48% discontinuation, mainly attributable to chemotherapy, because nobody wants to take indefinite pemetrexed maintenance. So there is a lot of dropouts. Grade 3 toxicities are osimertinib and plus chemotherapy combination 53%, and in the monotherapy is only 11%. Adverse effects leading to death 2%. 2% in the combination and less than 1% in the monotherapy. Next slide, please. Here also, this bar chart is showing that the grade 3 neutropenia and grade 3 and grade 4 thrombocytopenia. It is much more in the combination arm, and in the monotherapy arm, grade 3 and grade 4 toxicities are very less. So it is myelotoxicity is much more, mainly due to chemotherapy. Next slide. So what about the other combination chemotherapy with TKIs? The Japanese study, the Geftinib with chemotherapy versus Geftinib alone, 65 percentage grade 3 toxicity. In the TMH study, again Geftinib plus chemotherapy 75%. In the Flora 2, it is on the lines of the previous studies, it's 64%. Most common grade 3 events are hematological across the studies, and most common adverse effects are anemia, neutropenia, thrombocytopenia in the Flora 2. It is same as in the Japanese study and the TMS study as well. And the liver dysfunction is seen in around 18 to 29%. Rash is seen in 44% in the Flora 2. Next slide, please. So you can see that the combination scoring in the PFS 25.5 months with the combination versus 16.7 months with monotherapy. Again, it is scoring when there is upfront CNS mets. The PFS is 24.9 months versus 13.8 months with monotherapy. Again, it is showing an improved response and improved PFS in the subset of L858R, that is 24.7 months versus 13.9 months. Next slide, please. So what we have learned is that this combination is an excellent option in the first line where there is upfront CNS metastasis, and when there is L858R. But otherwise, exon 19 osimertinib is also an option, and we know that amivantamab and lazertinib has scored over osimertinib in the first line, so that is also an option. And in the second line, datopotamab, that is an option, antibody drug conjugate after osimertinib progression, and amivantamab lasertinib. If you have not used in the first line, that is an option. Carbopem with amivantamab is an option. With osimertinib monotherapy in the first line, and carbopem amivantamab and lasertinib, that is also an option if you have used osimertinib in the first line. Next. So this is an interesting concept. This risk-adapted trial design, EGFR Schedder study. That is, you are using osimertinib for 3 weeks, and if the circulating DNA is positive at the end of 3 weeks, you are adding additional therapy. Otherwise, circulating DNA negative, then you are using monotherapy alone. And this study will answer high patient whether high patient with a high tumor, high risk patient with high tumor burden will benefit more from the combination, and easier to choose patient who will have maximum benefit with the combination. Next slide, please. So to summarize today's presentation, osimertinib with combination chemotherapy has shown a meaningful PFS benefit compared with the monotherapy alone, and it has got a hazard ratio in the FLORA2 study of 0.62, and investigator assessed the median PFS is 25.5 months, and the BICR associated assessed median PFS is 29.4 months, and additional benefit is seen in the CNS metastasis and L858R. CNS metastasis has got a PFS of 24.9 months versus 13.8 months, and the L858R, the 24.7 months versus 13.9 months. The safety profile is as expected with manageable toxicity, but it is much more toxic than the monotherapy alone. The hematological toxicity is mainly due to the chemotherapy. Next slide. I think that is the final slide. Thanks for listening. Any questions, I'll be happy to answer.
If there is no question, next session is also sponsored by AstraZeneca. For this, I would like to invite speaker Dr. Anshul Gupta sir. Sir is a consultant, Department of Medical Oncology at Max Hospital, Vaishali. It's over to you, sir.
Can you please just start my slides so that you
Yes.
can speak? Okay. So very good evening, everybody. Thank you, AstraZeneca. Thank you, Dr. Chaudhary, for giving me this opportunity. And today we'll be talking about the stage 3 unresectable non-small cell lung cancer in the changing treatment landscape and the medical oncologist perspective over it. Next slide. So this is the schema of our slideshow that we'll be discussing, the complexity of unresectable NSCLC, role of concurrent CTRT as the standard of care, role of consolidation using various strategies, then the Pacific and the LAURA trials, and the summary of the guidelines. Next slide. So, well, NSCLC stage 3A to 3C, comparison of lymph nodal and the tumor anatomy. So 20 to 30% of the patients will have stage 3 at the initial diagnosis. It's, locally advanced stage 3 is a heterogeneous disease subclassified into stage 3A, B, and C based upon, the size and the nodal pattern. So stage 3A is either T1 to T2 with N2 disease, or T3 to T4 with N1 disease, or T4 disease with node 0. Stage 3B is N2 but with T3 to T4 or N3 disease. And stage 3C is either T3 or T4 along with N3. So this is how stage 3 is subclassified into 3A, B, C. Next slide, please. So next slide. Well, this is just exactly what we had discussed previously. Uh, but if you look at the survival in terms of 2-year OS and 5-year OS percentage, stage 3A is 2-year OS is 65 and 5-year OS is 41. As we go along to stage 3C, it reduces to half, as in 2-year OS is 30% and 5-year OS is 12%. They practically behave like more like stage 4A disease. So next slide, please. Next slide. So the current standard of care is, of course, CTRT in unresectable stage 3. Now, various iterations of CTRT can be done. So it can be induction chemotherapy followed by radiation. Concurrent CTRT, as is one of the most common variants to be used. Then induction chemotherapy followed by concurrent radiotherapy, and concurrent radiotherapy along with chemotherapy followed by consolidation chemotherapy. So the number 2 and number 3 are the ones which are most commonly used, but then all of them are used in some scenario or the other. Next slide. So, well, this is the stage 3 unresectable NSCLC guidelines from NCCN, and the ones mentioned in yellow boxes, of course, definitive concurrent chemoradiation is category 1 indication. And yeah, next slide. So we'll be talking about the role of consolidation therapy in improving outcomes. Next slide. So consolidation therapy post chemoradiotherapy. These are the various trials that have used various consolidation strategies, as in docetaxel or docetaxel cisplatin, PEMCIS combination, or consolidation radiation, consolidation with gefitinib, or consolidation with cetuximab, and not almost all of them have not proved to be very good, except with the exception of consolidation of placebo versus gefitinib, wherein the hazard ratio has been good, 0.63. Next slide. So outcomes in the patients with unresectable stage 3 NSCLC based upon specific trial we'll be discussing in the next few slides. So the trial design is that patients with stage 3 locally advanced unresectable NSCLC who have not progressed following definitive platinum-based CTRT, that is, they've received at least equivalent to 2 cycles, 18 years or older, and PS0 to 1. So these were randomized to durvalumab 10 mg per kg every 2 weekly for 12 months, or by placebo. And the co-primary endpoints were PFS by blinded independent committee review and overall survival. Next slide, please. So the curves, they separate fairly early, that is almost prior to the 3-month mark. And the stratified hazard ratio for death is 0.72 with the 95% confidence interval of 0.59 to 0.89. So the curves, they separate quite nicely from the beginning and remain separated till the end, with a 60-month overall survival having almost close to 10% advantage, 42.9 versus 33.4% in the durvalumab consolidation arm. So this has been the standard of care previously or till now. So next slide. Yeah, so again, in the forest plot, almost all of them they did well, except for probably PDL1 less than 1%, but this is not powered to be concluding anything. This is post hoc analysis. Next slide. So outcome of progression-free survival with addition of durvalumab consolidation would be, again, the p-value is very significant in this, with a hazard ratio of 0.55, and the 95% confidence interval being 0.45 to 0.68. Next slide, please. So again, a durable PFS of 33% at 5 years. So even in this forest plot, all of them did better. Next slide. So there is no approved targeted therapy for unresectable stage 3 NSCLC, specifically the ones who are EGFR mutated NSCLC. So if we have a look at the Pacific trial, again, it was 42.7 months. The median PFS was 11.2 versus 10.9 months. And the NASAR trial, osimertinib versus durvalumab, it also in that the real world PFS was not reached in the osimertinib arm versus in durvalumab it was 12.7, and in the median OS was not reached again in the osimertinib arm versus 54 in the durvalumab arm. So I think this shows that probably the patients who have EGFR mutated NSCLC stage 3, the standard durvalumab probably is not doing justice to them, and they need better consolidation strategies. Next slide, please. So outcomes in patients with unresectable stage 3 NSCLC EGFR mutated based upon the LAURA trial are as follows. Next slide. The trial schema included the patients receiving osimertinib in the patients who were EGFR mutated after CTRT. So the PFS was very highly significant, and the separation of the curves was seen very early, as I said previously as well, less than 3 months. The separation started to be very apparent, and the PFS for the hazard ratio for PFS was 0.16, exceptional PFS hazard ratio. That is 84% less chances of event of progression as compared to the other one. Sorry, my network got a bit crashed. Next slide, please. Yeah. So if you look at the progression-free survival forest plot, almost all the subgroups they favored well for osimertinib addition. Next slide. So if you look at the CNS PFS, again, it was early separation of curve with reduced risk of CNS progression was seen, with the osimertinib with a hazard ratio of 0.17. Again, it was a very brilliant hazard ratio with a 95% confidence interval of 0.09 to 0.32. Next slide, please. So CNS PFS again, it was not reached in the osimertinib arm as opposed to 14.9 months in the placebo with a hazard ratio of 0.17. Again, 41% experienced CNS events in the placebo group versus only 20% experiencing progression events in the osimertinib group. Reinforcing osimertinib CNS protective event even in this subset of patients. Next slide. So the risk of CNS progression was seen, in more in the in the placebo group as compared to the osimertinib group. And if you see the osimertinib group represented by blue, the various CNS progression, non-progression, non-CNS progression and death events in the osimertinib group are stacked below the placebo groups in the yellow above. So the cumulative incidence rate of CNS progression at 12 months was 9% in the osimertinib versus 36% with the placebo. Next slide. So time to distant metastasis or death by blinded independent committee review was also meaningfully improved by osimertinib as compared to the placebo arm with hazard ratio of 0.21, which is exceptional, and the median was not reached in the osimertinib arm as compared to the placebo having 13 months. So the patients who have not experienced the event of interest by the time of data cutoff were lost to follow-up. And the next slide. So the safety summary, I think more or less the adverse events were slightly higher in the osimertinib group, but leading to discontinuation were not exceptionally high, 13% versus 5% in the placebo group, and grade 3 adverse event was slightly higher, 35% as compared to 12% in the placebo group. But given the exceptional results that they have shown, I think the risk benefit analysis favors the addition of osimertinib in this particular subset of group. Next page, slide. So the major adverse events with osimertinib was radiation-induced pneumonitis, as has been known. Diarrhea and rash are again the class effects of PKIs, and other decreased appetite and decreased TLC and pneumonia are the rare side effects. So interstitial lung disease was reported in 8% in the osimertinib arm, and majority were grade 1 or 2, and grade 5 was only a single patient. Next slide. So these are the current treatment guidelines to manage unresectable stage 3 disease. The NCCN guidelines, they say that give CTRT and then consolidation durvalumab or osimertinib in EGFR exon 19 del or L858R. ESCO guidelines also mention the same thing. They recommend EGFR mutation status and PD-L1 expression testing. And ESMO guidelines also, they although do not mention categorically osimertinib, but they mandate EGFR mutation status and PD-L1 expression testing, thereby excluding such patients from durvalumab. Next slide. So to summarize my presentation, concurrent chemotherapy with radiation remains the standard of care, offering a median OS of 17 to 28 months, depending upon the patient's status of performance status or staging. Current scenario accounts for almost 30% of NSCLC, in stage 3 are unresectable. Pacific trial demonstrated a significant PFS 16 versus 5, and the hazard ratio for OS was 0.72 for consolidation durvalumab post CTRT. The LAURA trial in EGFR mutant patients showed median PFS of 39 versus 5 months, with an exceptional hazard ratio supporting osimertinib as new consolidation option. Current guidelines, including NCCN and ESMO and ESCO, they recommend the PD-L1 durvalumab for PD-L1 positive tumors and consider osimertinib for EGFR mutated cases as a category 1 indication or recommendation. I think that should be the last slide. Next slide, please. Yeah. So I'd like to thank everybody for patient listening, and I'll be happy to answer any questions.
If there is no question, we will move forward. Next session is sponsored by Johnson and Johnson. For this session, I would like to invite Dr. Priyanshi. She is an associate consultant, Department of Hemato-Oncology and BMT at Fortis Hospital, Noida. It's over to you, ma'am.
Good evening, everyone. So today I will be discussing about multiple myeloma, treatment modalities in multiple myeloma. Please excuse for my voice as I am having laryngitis, but I would be as audible as possible. So multiple myeloma, the treatment has been redefined because now we are having multi-modalities of treatment, like monoclonal antibodies are there, and we have bispecifics also, which are new, but we have a new hope in patients who are relapse refractory multiple myeloma, and they have relapsed even on proteasome inhibitors and at least 3 lines of therapy, including daratumab, that is CD38, anti-CD38 antibodies. So plasma cells, as we all know, is a neoplastic plasma cell disorder. Next slide, please. The clinical presentation may vary. It can be a hematological presentation. It can be a renal, skeletal in form of lytic lesions, and other signs can be there like neurotoxicity, neural damage, hyperviscosity syndrome, and light chain disease. Next slide. The diagnostic criteria and cytogenetic feature and staging we will discuss in brief. Please, next slide. So we all know that the CRAB criteria is important for the diagnosis of multiple myeloma. It is myeloma defining event. C is for hypercalcemia, R for renal impairment, A for anemia, and bone is for lytic lesions. Next slide, please. So there is a cytogenetic risk factors which we should consider. It can be a high risk or standard risk. So a high risk involved deletion 17p, TP53 mutation, deletion 1, the gain 1q, and with all the other translocation like 414, 1416, and 1420, and high beta 2 microglobulinemia. Other are standard risk. Next slide, please. So the diagnosis of multiple myeloma need all these investigations, CBC, LFT, KFTs, including comprehensive myeloma panel, which comprise of serum protein electrophoresis, immunofixation, beta 2 microglobulin, facial analysis, including PET-CT or MRI. Next slide. I won't discuss much about it because X-ray and we can use different radiological modality, but the more specific is whole body MRI followed by PET-CT for lytic lesions. Next slide, please. So we use revised international staging system to standardize this multiple myeloma into three stages, that is 1, 2, and 3. It also takes into account cytogenetic risk stratifications as well. Next slide, please. So the treatment selection totally depends on patient. The patient factor like age, ECOG performance status, social status, disease-related factors like ISS stage, aggressiveness of the disease, how many times the disease has relapsed, what stage it is, cytogenetic abnormalities, risk, as well as treatment-related factors like how the disease has behaved as first line, refractory disease, how many lines of therapies has already been used, and other factors like where is the patient from and the finances. Next slide. So the current treatment, we all know proteasome inhibitors like bortezomib, immunomodulator drugs like lenalidomide, pomalidomide, monoclonal antibodies are there, steroids, chemotherapy. We all have used this. Now we are coming to T cell bispecific antibodies as well as CAR T cell therapy are also in line. Next slide, please. So the treatment of newly diagnosed multiple myeloma we'll discussing about. So the multiple myeloma treatment totally depend if the patient is transplant eligible or it's not eligible. The patient who is eligible is usually younger, mainly less than 60 years of age, has a good performance status. In those patients, we do induction chemotherapy and consolidate them with transplant. Next slide, please. Next slide, please. So in multiple myeloma, we have multimodalities of treatment. Like we started with proteasome inhibitor like bortezomib, but now we have carfilzomib and other medicines as well. Lenalidomide, pomalidomide, earlier it was there. Now from 2020, we have daratumab, which is anti-CD38 antibody. And now in 2025, we have teclistamab, and we are in line with CAR T cell therapy as well. Next slide, please. Autologous transplant, if the patient is a transplant eligible patient, he has a good performance status and is a younger patient with less comorbidities or the diabetes and hypertension is in control and the finances are also allowing. So patient can undergo autologous transplant, which is a very good treatment modality to control multiple myeloma, and it is a less than 1% mortality. Next slide, please. So, next slide, please. Next slide, please. Next slide. So, it is important to understand that why these newer therapies are coming in line. So, we should understand that as if the patient relapses on the first line of therapy, then the chance of the performance status as well as overall survivals decreases with further lines of therapy. So now there is a concept of quadruplet induction, if possible, for the patient. So much so that the patient maintains the disease of multiple myeloma as at first line itself. Next slide, please. So as we can see that once there is an active myeloma, so first line therapy, if there is an increased remission or there is increased disease control in a patient of multiple myeloma, so it is better for the patient rather than if the patient relapses on the first line of therapy, the further line of therapy, duration of response is lesser as depicted in this diagram. Next slide. So in multiple myeloma, the tumor burden contains significantly more mutation at relapse than at diagnosis. That is why it is better to control the disease at first at induction itself. Next slide. Next slide, please. So the patient can be divided into standard risk and high risk as I depicted according to the cytogenetic risk, according to the RSS staging. So usually a patient of multiple myeloma are frail patient. They are elderly patient and they are usually more than 65 years of age. They have other social issues as well. In those frail patients, we should introduce daratumab at first hand. We can use VRD up to 12 cycles and we can introduce DARA as well. Even in not frail patient, we can induce daratumab as a quadruplet therapy during induction, which causes prolonged disease control. Even in high risk patient, we must induce DARA so much so that the depth of response is good, and thereafter we can take the patient for transplant and we can control the disease for a longer duration of time. Next slide. So in MSPART, Mayo stratification for myeloma and risk adapted therapy guidelines also in transplant ineligible patients also we should stratify them. They are standard or they are high risk, as I told in the cytogenetics as well. So in those patients, we should give at least 9 cycles of DARA VRD or for frail patient DARA RD. And even in high risk myeloma patient, we should give at least 9 cycles of DARA VRD or if for frail patient, we should give DARA RD for 9 cycles, followed by DARA maintenance. Next slide, please. Both the patients who are standard risk and high risk, if they are transplant eligible after 4 cycles of induction chemotherapy, 3 to 4 cycles of induction chemotherapy, either we should go for early stem cell transplant. If you want to give further cycles of chemotherapy before transplant, the cryopreservation of stem cells should be done, followed by LEN maintenance. But if a patient is of high risk, then it is better to give early transplant after 4 cycles of therapy, followed by BOTI and LEN maintenance. But as I will tell you that in maintenance, I usually give daratumab maintenance. Next slide, please. So in MSPART guidelines, transplant eligible, as I told, that according to the risk stratification, treatment should be guided. Next slide, please. So in newly diagnosed multiple myeloma management, according to 2025 guidelines, the patient who is an autologous candidate, they should be divided into standard risk and high risk. The one who are a standard risk should undergo quadruplet therapy. Why quadruplet therapy? To increase the depth of response. Followed by 4 cycles, they should undergo autologous transplant. And followed by that, LEN and daratumab maintenance. Even in high risk patient, it is better to give LEN maintenance, daratumab maintenance, as well as some proteasome inhibitor, can be bortezomib. Even in a non-transplant patient, non-transplant candidate, DARA RD should be used, okay, or quadruplet therapy as induction, followed by DARA maintenance until progression. Next slide, please. Daratumab can be used as a IV drug, that is according 16 mg per kg, or can be used as subcutaneous drug. The advantage is that the subcutaneous drug has a decreased risk of adverse reaction like allergic reaction, as well as can be administered over 3 to 5 minutes on OPD basis, daycare basis. So that is why it makes more efficacious in terms of quality of life as well as patient compliance. Next slide, please. Next slide, please. So goal of therapy is actually to reduce symptoms of active myeloma. That we can do only if we have a greater depth of response, prolonged response, improve quality of life, as well as maintaining response as well as tolerability to therapy. It also enhances overall survival. Next slide, please. So, frontline treatment option for newly diagnosed multiple myeloma who are not transplant eligible. These two study was done in these patients, Alcyon and Maya. Next slide, please. So these were eligible transplant ineligible patients. Okay, the performance status was good, and the creat clearance was more than 40. There was no grade more than 2 peripheral neuropathy, and no more than 2 grade neuropathic pain was there. In those patients, they have used bortezomib, melphalan, prednisone, and they have given 9 cycles. In the other arm, they have used daratumab and the same VMP schedule as I told above into 9 cycles. But in the second arm, they have given daratumab 10 cycles 4 weekly, and thereafter they have followed up the patients. Please, next slide. So, as depicted in the diagram, the second graph, you can see that 36% reduction in the risk of death was there, and 24.9% patient in the DARA VMP arm were still receiving DARA monotherapy. So, it's as a maintenance they have used. Next slide, please. Then the other study was also done in this transplant ineligible patients, newly diagnosed transplant ineligible patients. They have given daratumab as well as they have given dexa and len. So the other arm they have used RD. They have removed the dara. So the end of treatment they have stated after 30 days. Next slide, please. So you can see that in the arm which was having daratumab, median survival was more. Next slide, please. %35 reduction in the risk of death observed in daratumab arm as compared to the arm which was not containing dara. So the overall median follow-up was more. Next slide. Next slide, please.
Dr. Priyanshi, sorry to interrupt you. We are running short of time. Please conclude your talk in next 2 minutes.
Can you show me that one slide of teclistamab, please? Last. Next. Yes. Just last slide. Last slide, please. Just a few words about teclistamab. So, the patients who have relapsed, like multiple myeloma is a disease which is even happening in younger patients. So, we are seeing patients who are in their third or fourth decade of life. So, these patients might come up even after 3 lines of therapy, they might relapse. So in those patients, teclistamab is a drug which we can use. It is a bispecific antibody. It directed, as in the diagram, it directs against two things. That is, it is direct against this both CD3, that is expressed on T cell, and BCMA expressed on multiple myeloma cell. And then this CD3 T cell, it directs against this BCMA expressing multiple myeloma cells. Next slide, please. So it is important to understand that teclistamab can be used as a monotherapy in adult patients who are relapse refractory for at least 3 prior lines of therapy. All right. So that is immunomodulators, proteasome inhibitors, and anti-CD38 antibodies. It is usually used first in as a step-up doses. Okay, as in the diagram, 0.06 mg per kg followed by 0.3 mg per kg followed by 1.5 mg per kg. Why? Because this is associated with CRS. Next slide, please. So teclistamab is this is used according to the Majestic phase 1 and 2 trial which was done. Okay. So the key eligibility criteria were the patients who were relapsed refractory at least for more than 3 lines of therapy, and who has extramedullary disease, and who has a better hemoglobin and platelet count and better performance status. The next slide, please. The overall response, see, we have to understand that in this study they have taken into account those patients who are high risk category, who are relapse refractory over 3 lines of therapy, and who have extramedullary disease. So these patients actually are quite sick. So next slide, please. So as you can see, the overall response rate is good. It is 63%, and the CR is of 46.1%. All right. And it has been followed up for 2.5 years, as in the diagram. So we should understand that there are newer therapies which are coming up. There is always hope for patients of multiple myeloma. And there are various trials which are going on in India as well, where we can enroll such patients who are having a high disease risk, relapse refractory, even after 3 lines of therapy, and having extramedullary disease, even plasma cell leukemia. So those patients we can enroll in trials as well. So, therefore, I would like to conclude that multiple myeloma is mostly in older age group, but now we are able to see patients who are in their third and fourth decade of life, and in such patients, we should think about the first line therapy as quadruplet therapy, because the longer the duration we have on the after first line therapy, it is better rather than having a relapse disease after few years. MRD, usually people don't do it, but because it does not predict the progression free survival or overall survival, but still should be done as a study purpose. And research and various investigations should continue in this particular field, so much so that we can control the disease better. Thank you. Thank you so much. Any questions hereafter?
Is there any question? If no question, we will move forward. Next session is sponsored by Rose. For this session, I would like to invite Dr. Mohit Saxena. Sir is a consultant and head of Department of Medical Oncology and Hemato-Oncology, Manipal Hospital, Palam Bihar, Gurgaon. It's over to you, sir.
Hello, very good evening. Thanks, Dr. Rakesh R.K. Chaudhary, sir. Thank organizer for giving me the chance, opportunity. My slides are visible, I think, and I am audible.
Yes, sir, you are audible and slides are visible.
Okay. So this session is sponsored by Roche. The topic given to me is polatuzumab vedotin in a previously untreated diffuse large B-cell lymphoma. So of course we know a lot about the DLBCL. We will discuss what is new here in the coming slides. So as we know that almost 30% are Hodgkin and rest remaining 70% are non-Hodgkin lymphoma. And among the non-Hodgkin, the B cell are more common, that is almost 85%, and T and NK cells constitute 15%. But among the B cell, the DLB cell is the most common lymphoma, that is almost 42% in our country. So, of course, the likelihood of cure is highest with the treatment in the first line setting. The first chance is your best chance. Once we treat the DLBCL patient with first line therapy, then almost 60% of patient gets cured and their life expectancy is similar to age and sex match control. But what happened to the remaining 40% of patient? They have progression, they receive the second line therapy, and they might get chance of curative treatment like CAR T cell or auto transplant, but almost only 25% of second line DLBCL patient gets cured with this treatment. There are many hurdles so that not everyone gets cured after progression of on the first line therapy. What happened to the remaining? They keeps on changing the therapy. Their intent of treatment remain palliative. So that's why we should do something to give the best chance of cure to these patients. Now, of course, if we talk about the history, then in the 1976 there was CHOP. Then in 1997 rituximab was introduced for the first time, and in 2002 for the high-grade lymphoma patient, the R-CHOP became the standard of care. Then, then a long question. For almost 2 decades, nothing new happened because there was. It's not like that we have not tried anything, but nothing successful happened. So R-CHOP remains the standard of care for DLBCL patients. Now, but R-CHOP doesn't cure all DLBCL subgroups. We know that patients with low IPI, early disease stage, GCB phenotype do well, but they are highly curable. But what about other extreme? The patient with high IPI, age 60 or more, non-GCB phenotype, well protein expression, make BCL2 rearrangement. They have low curability. So we should try to do something for these patients. Now, of course, if we talk about the cellular target in anti-lymphoma, then of course we know that for the CD19, there is antibody drug conjugate like loncastuximab, tacirine, and tafasitamab. If we talk about PD-1 and PD-L1 inhibitor, then we have immunotherapy. If we talk about CD20, then now we have the bispecific antibody as well, like glofitamab. And we have immunomodulators like lenalidomide, BTK inhibitors like ibrutinib, acalabrutinib. But here we will talk about CD79B inhibitor, that's polatuzumab vedotin. And of course, as the name suggests, it is antibody drug conjugate. So the antibody binds to CD79B and then there is the chemotherapy drug is released inside the cell. So that's what I was discussing earlier, that it's not about that we have not tried anything. Say we have tried to enhance the anti-CD20 like GC-CHOP. What is GC-CHOP? The G-CHOP, it is obinutuzumab plus CHOP. But we tried to add another targeted therapy like lenalidomide in the R2 CHOP, that is the robust trial, we have tried to add bortezomib, ibrutinib, bevacizumab. We have tried to enhance chemotherapy like adding gemcitabine, but there was a lot of dose limiting toxicity. We tried to intensify chemotherapy with the epoch or arch 14. We tried to add maintenance like angiostorin maintenance, everolimus maintenance, and rituximab maintenance. But what was the end result? You can see among all these diseases, hazard ratio is almost 0.85 to 0.92 or something. So there is not much difference. So most of this, there is nothing were practice changing. Of course, for the gut feeling, we might be using for many of these regimen because we think that our patient might do worse, so we should do something. But as nothing was proven, so RCHOP remained the standard of care for the more than 20 decades, 2 decades, despite knowing that that is not suitable for everyone. So then there is a breakthrough. We are talking about the polatuzumab. So Pola R-CHP was become the only regimen that approved in the last 20 years that has improved treatment outcome in first line DLBCL patient. How? That is, of course, they have improved outcome. That's why it leads to approval of European Commission in 2022 and FDA and CDSCO approval in 2023 for the first line treatment of previously untreated DLBCL patient. So why did this combination get approval? We'll see. Now, of course, polatuzumab, as I was discussing, it was antibody drug conjugate. So it targets CD79B. Then after touching to CD79B, the drug is antibody drug conjugated receptor complex get internalized. Then there is release of monomethyl orostatin E, that is microtubule inhibitor. So that leads to microtubule disruption and ultimate result is apoptosis. So of course, we are targeting the CD79B and also releasing the chemotherapy drug inside that cell. So that's the concept of antibody drug conjugate. And as we know that CD79B is ubiquitously expressed in the DLBCL. So it's just like CD20, so that's it's quite common. So almost all cells are expressing CD79B in DLBCL patients. Now, this is the why this is drug is getting so much attention, why it is getting so much approval. So this is based on this trial, that's Polarix trial. Polatuzumab vedotin in previously untreated diffuse large B-cell lymphoma patient. So what is that? Why they have tried to do? They have replaced the vincristine with polatuzumab, and again it was given every 21 days for 6 cycles as we do in the our job. Oh, this is the trial design of GEOS 39942 Polaris trial, that is phase 3 study evaluating polar CHP versus RCHOP in first-line DLBCL patients. So the inclusion criteria was previously untreated DLBCL patient with 18 to 80 year of age, IPI 2 to 5. So IPI 1 was not there. If the patient is very good risk, the IPI is only 1, then this drug is not for those patients. That's what we can understand with this trial. And ECOG performance status of 0 to 2. So even ECOG 2 were taken in this patient, and they were treated with either receive polar CHP or for 6 cycle or RCHOP for 6 cycle, and then rituximab was given for on cycle 7 and 8. So of course polatuzumab in a dose of 1.8 mg per kg, and the cycle was repeated every 21 days. Now the primary endpoint was PFS, but the secondary endpoint was EFS, PET-CR at end of treatment, overall survival and safety. So what they found? Of course, if you look at the baseline characteristics, then of course the median age was 65 years, so sizable number of patients were elderly. The 54% are male. ECOG 2 is almost 15 to 70% patients, so many of patients have ECOG 2. Now, if you look at the other factors, then there are many high risk patients. Like IPI 3 to 5 are in the 62% of patients. If you look at the bulky disease, then almost 43% patients in both arms have bulky disease. If you look at extraneural 2 or more, then it is almost 48% patient. If you look at NRB stage 3 or 4, then it is almost 89% patient. So many of them are high risk patients. Of course, we know that they don't do well in comparison to other patients. If you look at the histology, then DLBCL was in 83 to 84% patient. High grade B cell lymphoma, double hit or triple hit was almost in 9 to 11% patient, and there are other large B cell lymphoma as well. If we try to identify cell of origin, then almost 30% patients are having 30 to 35 patients are having ABC type, and GCB type are in almost 50 to 55% patient. So all subtypes are taken. It's not like they have tried to select only the good risk patient. Now, the Polarix met its primary endpoint. We want PFS, we got PFS. To a 24-month PFS was 76.7% with polar CHP versus 70.2% with RCHOP. So there was delta of 6.5%. And if you look at the hazard ratio, then it is 0.73. So that is 27% relative risk reduction. So it got its primary endpoint of the improving PFS, and that's why it became the only regimen approved in the last 20 years that has improved outcome. As we were discussing that in the other regime, the hazard ratio was almost 0.9, 0.92, or even 0.856. There was nothing like that impressive 0.73. So if you look at the PET CTCR at the end of treatment, then it was 78% with polar RCHP and 74% with RCHOP. And of course, those patients who are achieving complete response, we want to look at disease-free survival. You might be thinking that those patients achieving CR doesn't have much difference, but here you can see there is still hazard ratio of 0.70. So their polar RCHP is superior to RCHOP in the disease-free survival, even in those patients who are achieving complete response after first-line treatment. Oh, if you look at the investigator assessed PFS, then of course you want to know the cell of origin. So this is a very important slide. You can see in the ABC subtype, the 2-year PFS was 85% with the polar CHP versus 56% with RCHOP. So you can see almost 29% difference is there. So the delta is 29% and hazard ratio is 0.34. So almost 66% relative risk reduction. So that's a huge difference. You can see curves are wide separate. In the GCP arm, of course, there's hazard ratio is 1.03 and unclassified is 1.92. So of course, this is subgroup analysis, but you can see that at least we are finding one subset that is going to be benefited with this regime. And in other subtype as well, we can at least use this. Now, in the dark zone signature positive DLBCL, say even the GCU subtype, many patients are having dark zone signature. What is dark zone signature? That is a double hit, MYC and BCL2 positivity. So the gene rearrangement is positive. So if you look at the dark zone signature positive DLBCL, then here as well the 2-year PFS is 75% with polar CHP versus 64% with RCHOP. So hazard ratio of 0.74, 0.47 and delta of 53%. Again, the curves are separate. In the negative, there was not much difference, but so at least we can see that in the dark zones feature positive DLBCL, they do well with polar CHP versus RCHOP. Now, another subset where we can see there is difference is great, that's elderly, 60 or more year of patients. Here you can see hazard ratio of 0.64 for PFS and hazard ratio of 0.74 for OS. So of course, there is a PFS benefit and OS benefit in elderly patients. Of course, we are always concerned about these patients. So here you can see that this regimen is superior. Now, if you look at the overall survival analysis, so initially it was 2-year update was there, so the hazard ratio was 0.94. And of course, you can see the curves are almost overlapping, but slightly the green one was slightly on above. So there might be some difference, but of course, was not significant. We need more longer follow-up. We will talk about the longer follow-up in the next few slides. Now, of course, patients with polar HP require less subsequent therapy. That is 30.3% with the RCHOP versus 22.5% of with polar CHP. You can see almost difference of 8%. So they require 8% less subsequent therapy. They become cured. They will not require anything else. Now we will talk about the 5-year update. What, of course, the benefit was well sustained. You can see that the trial design, the median PFS follow-up was 54.9 months and OS follow-up was 64.1 months. And now, if you look at the PFS, now the PFS benefit was maintained. Hazard ratio was 0.73 in the 2-year and it is 0.77 at 5 years. So there is 23% relative risk reduction. And at 5-year, PFS was 64.9% with polar CHP versus 59.1% with RCHOP. So of course, the PFS benefit was maintained. Those patients achieving complete response, the DFS benefit was maintained. You can see curves remain separate. The 2-year it was 0.70, at 5-year it is the hazard ratio is 0.75, so 25% relative risk reduction. And at 5-year DFS was 71.8% with polar CHP versus 66.5% with the RCHOP. So of course, you complete even those patients with achieving complete remission, the DFS benefit remains at 5 years. Now, of course, if you look at the subsequent therapies, then they are 23% fewer. You can see 61.7% with RCHOP requiring subsequent therapy, while only 38.3% patient with polar CHP require subsequent therapies because higher number of cures, so less subsequent therapies are required. If you look at the OS, then again, I would like to say initially it was 0.94. Now it has increased to 0.85. So there is 15% relative risk reduction. And you can see the numerically fewer deaths. There was at 5 years, there were 79 deaths at polar CHP versus 91 in RCHOP. So of course, we require longer follow-up because of course median is not reached. But you can see that curves are slightly separate in comparison to previous. So maybe in the longer follow-up, we might find the OS benefit as well. Of course, we will have to wait for that. Now, if you look at the why there is death, so death related to disease progression were fewer in polar CHP versus RCHOP. They were 9.1% in polar CHP versus 11.6% with RCHOP, and they were 50% and 55% in comparison to the total deaths. So you can see numerically the lymphoma related deaths were less with polar CHP, and lymphoma unrelated deaths were almost similar. You can see others, there is hardly any difference. Now, if you look at the subgroup analysis, then again you might think that what we were discussing earlier, the benefit is seen in the ABC subtype, that's true. Benefit is seen DLBCL and high-grade B-cell lymphoma, double-hit antibody, that's true. Double expressor lymphoma by ISC, they are getting benefit, that's also true. But of course, this is a subgroup analysis only. So of course, the number of patients are less in particular subset. So we should interpret it cautiously because we can't label that this patient will not get benefited this based on the subset analysis. Now, if you look at the expanded population, if we add the Chinese, of course, we always talk about the China. So here as well, to complete the count, the Chinese cohort was added, and you can see that here median follow-up was 54.7 months and median OS follow-up was 63.3 months. And what we find that the benefits were maintained if you add Chinese as well. The PFS hazard ratio is 0.80, the DFS hazard ratio is 0.81, for OS the hazard ratio is 0.83. So here as well, we are finding the same outcome as we were discussing earlier. Now, if you look at the risk analysis again, then there is at 5 year 9.02% lymphoma-related death with polar CHP versus 12.05% death with R-CHOP. So again, lymphoma-related deaths are less, numerically less with polar CHP versus R-CHOP. Of course, non-lymphoma-related deaths were similar, that is almost 8.5% in both arms. Now, if
Dr.
you look
Mohit,
at
sorry to interrupt you. We are running short of time. Please
yeah,
conclude
just
your
I'm just
talk.
finishing it. So you can see the adverse effect profile, then they are quite matched in both arms. If you look at the adverse event of special interest and the cytopenia, the difference in both arms is less than 5%. And of course, carcinogenicity and cardiac arrhythmias are less with polar CHP in comparison to R-CHOP. So they have concluded that 5 year extended follow-up shows consistent benefit of PFS and DFS in polar RCHP was superior to R-CHOP. There was fewer anti-lymphoma treatment required, numerically fewer death, favorable outcome, safety was similar. So 5 year data confirmed that polar RCHP should be standard of care for patients with previously untreated intermediate or high risk DLBCL. So prolonged follow-up is planned, of course, we'll see later on. And that's reflected in guideline as well. You can see if the IPI is more than 1, that's 2 or more, then of course in the stage 1, 2 and stage 3, 4 as well. Polar CHP is category 1 indication by NCCN. So to conclude, the effect of Polaris trial is that Polaris is the first trial in over 20 years to show a meaningful improvement in the benefit risk profile over R-CHOP in an international phase 3 double-blind randomized controlled trial. Long-term follow-up analysis of Polaris study confirmed an ongoing and encouraging PFS benefit and indicates a positive trend in OS in favor of polar CHP. The benefit of polar CHP holds even more importance in setting with the limited availability and access to efficacious treatment in relapsed refractory DLBCL setting. So polar CHP is category 1 preferred treatment regime as per NCCN guideline and also recommended by NICE guideline. With this I finish. Thanks.
Thank you, Dr. Mohit, sir. Is there any question? If there is no question, we will move forward. For the next talk, I would like to invite program convener, Dr. R.K. Chaudhary, sir. Sir, it's over to you.
Thank you so much. Would you be sharing the slides?
Yes, sir.
Once again, very warm good evening to everyone, and thanks so much for Kabi, Freshness Kabi, for providing me the opportunity as well as the slides. So I'm going to briefly discuss about the role of the clinical nutrition in cancer patients. What is the cachexia? How we define cachexia? How much it is common, and what can be done in the cancer patients once the patient present with the severe cachexia or the severe malnutrition. Next slide, please. So, syndrome of cancer cachexia is synonymous with the severe weight loss, but it is multi-layered, multifaceted syndrome of complex etiology, of which weight loss is only one component. At the core lies the problem of progressive tumor growth and catabolic side effect of the antineoplastic therapy. Next slide, please. So, cancer is a hypercatabolic state with increased metabolic rate to the tune of 20 to 40%, increased fuel utilization with more fat oxidation and decreased glucose oxidation. Protein catabolism increases and protein synthesis decreases, and hormone status, insulin glucagon ratio decreases while the catecholamine and cortisol increases. Next slide, please. Please. So cancer and malnutrition and the weight loss. Protein patient with the cancer have altered nutrition status as presentation and it varies through the continuum of the cancer care. Most of the patient experiences unplanned weight loss leading to the diagnosis of the cancer. So there are certain number of patients who purely present with the weight loss is the as the only symptom, and evaluating the further they might lead to diagnosis of the cancer patient. And with the rough estimate, there are 30 to 85% of the patient with the cancer who reports the malnutrition. Malnutrition is associated with loss of lean body mass, which is called sarcopenia in patient with cancer, which is an independent risk factor for poorer outcome. 10 to 20% of the patient's death can be attributed to malnutrition rather than to the malignancy itself. Also, treatment emergent side effects are impending poor nutritional outcomes. So we have seen in clinical practice that those patients who present with severe malnutrition and a significant weight loss do have more side effects with the anti-cancer therapies. Next slide, please. Uh, uh, can you go to one slide back, please? So, what is the implication of weight loss or the muscle wasting in cancer? This is associated with fatigue and apathy, increased hospital length of the stay, and resulting into increased cost, increased susceptibility to infection, again leading to more hospitalization and more cost. Post-operative complication and the mortality increases, response to chemo and radiotherapy decreases, and there is increased risk of treatment-related toxicity, and overall this leads to poor quality of life. Next, please. So, cachexia does not happen overnight, and it's a progressive state starting from the pre-cachexia where the weight loss is less than 5% of. There is anorexia and increased metabolic changes. Cachexia is defined when the weight loss is more than 5% or the BMI is less than 20% with the body weight loss of more than 2% or the sarcopenia and weight loss of more than 2%. This is often reduced. There is often reduced food intake, and there is an increased systemic inflammation. And it is, if it is not addressed at the right time, that it might lead to refractory cachexia with a variable degree of cachexia. Cancer disease both pro-catabolic and not responsive to anti-cancer treatment, and there is a low performance score, and the usual survival is less than 3 months expected survival. This might lead to up to 20% of the cancer deaths. So there is a anorexia cachexia syndrome, which is the result because of the tumor and host competition. There is a change in the carbohydrate fat protein metabolism, and because of this change in metabolism along with the anorexia might be because of the disease per se, or it might be related to uh, extended effects of the tumor, like pain and vomiting, nausea, or it might be related to GI involvement or related to therapy. This ultimately lead to diminished intake and increased expenditure, and that leads to cachexia. Next slide, please. So these are the metabolic changes which we see in the advanced stage of the oncology patient. There is a release of cytokines like TNF alpha, interleukin 1, interleukin 6, interferon, STAT3. These works in the various organs. In the brain, they causes the anorexia with decreased food intake. In the muscle, they will result into insulin resistance, decreased synthesis, increased breakdown, and skeletal muscle and fat muscle wasting happens. In the liver, they might result into increased nitrogen loss, and there is an increased lipolysis. Next slide, please. So there are certain theories which says that cancer might be in fact a metabolic disease. So over the past decade, new discoveries in the cancer metabolism and research have strongly indicated that cancer is primarily a metabolic disease. And this was published in Carcinogenesis in 2014. Another paper was presented in a American Journal of Pathology again in the same year, that although cancer has historically been viewed as the disorder of the proliferation, and recent evidences suggest that it might be a metabolic disease. Next slide, please. So what are the effects of advanced stage of cancer on the metabolism? Just we discussed that there is increased co-recycle rate and loss of ATP. Glucose intolerance happens, peripheral insulin resistance occurs, and high rate of glucose turnover happens. In the fat, there is an increased rate of lipolysis, increased free fatty and glycerol turnover, hyperlipidemia happens, decreased lipoprotein lipase activity. Coming to the protein, there is increased protein turnover, poor adaptation to the new starvation state. Next, please. So there are a number of papers published in the very reputed journal, and what is the role of malnutrition and muscle wasting in advanced lung cancer, and there are multiple in various cancers. There have been articles. So specific to the lung cancer, there is high prevalence of malnutrition in patients with the lung cancer, specifically the advanced stage of the lung cancer, and reported rate range from the 35% to 69%. Malnutrition and associated muscle wasting are clearly negative prognostic marker in advanced lung cancer. Patient with the malnutrition should be urgently referred to dietary counseling, and guideline for the nutrition support should be followed. Optimal treatment of these syndromes will likely include nutrition and anti-cachexia intervention used in combination along with the anti-cancer treatment. Next slide, please. So to summarize, the malnutrition and loss of muscle mass are frequent in a cancer patient and have a negative impact on the clinical outcome driven by the inadequate food intake, disease physical activity, decreased physical activity, and metabolic derangement. Therefore, standard operating procedures, responsibilities, and a quality control process should be established at each institution involved in treating the cancer patient to screen for, to prevent, to assess in detail, monitor, and treat the malnutrition. Next slide, please. So, what should be taken care while treating the cancer patient? Along with the anti-cancer treatment, we need to focus on the malnutrition part also. So, there are prophylaxis and treatment should be done for the nausea, vomiting, mucositis, anemia, and neutropenia, because obviously they lead to the anorexia and poor food intake. Appropriate pain management should be done. Psycho-oncological treatment or counseling should be done. Exercise and physical activity should be encouraged. Nutritional support in the form of oral nutrition supplement or enteral or parenteral, depending on the patient's clinical condition, should be advised. Next, please. So we know that nutrition is an integral component of supportive care during the cancer treatment. Next slide, please. So nutrition therapy in oncology, it is evolving from the supportive care to anti-cancer treatment nowadays. Correction of malnutrition is the utmost important. Preservation of muscle mass as well as the function is required. Modulation of pharmacological and or physiological effect of the chemotherapy and radiotherapy should be taken care of. Next slide, please. So what should be the goal of nutrition? It should be to prevent and treat the malnutrition and cachexia, maintain and improve the muscle mass and the function, improve the compliance with anti-cancer therapy, reduce the side effect of anti-cancer therapies, and this will result into reduction in the side effect of anti-cancer therapy. It will enhance the efficacy of the multimodal therapies, and it will ultimately enhance the quality of life. Next slide, please. So glucose, we know that glucose is the primary metabolic substrate for the cancer, and during the treatment, there are certain suggestions that glucose deprivation should be followed in the cancer treatment. Fat is an ideal energy substrate, but utilization by the tumor is poor. So you can increase the fat or the lipids, especially during the chemotherapy, up to the 50%. The decision to initiate parenteral nutrition when clinically indicated, specifically in the severe acute mucositis, severe acute radiation enteritis, or intractable nausea and vomiting, intestinal failure due to bowel or GI obstruction, or extensive bowel resection, malabsorption, fistulas, dysmotility, or radiation enteropathy. These are the indications where the parenteral nutrition can be considered. Next slide, please. So nutrition therapy using a higher than usual percentage of lipid up to the 50% of the non-protein calories may be beneficial for those patients with a frank cachexia needing the prolonged parenteral nutrition. Therapeutic goal of for the parenteral nutrition in the cancer patient are the improvement of the function and outcome by preventing and treating the undernutrition enhancing the compliance with the anti-tumor treatment, controlling some adverse effect of the anti-tumor therapies, and improving the quality of life. So parental nutrition is recommended in patients with severe mucositis and severe radiation enteritis. Next, please. Supplemental parental nutrition is recommended in the patient as mentioned earlier. Parental nutrition is not recommended if the oral enteral nutrient intake is adequate. Perioperative parental nutrition is recommended in malnourished candidates for the artificial nutrition, where enteral nutrition is not possible. In hepatological stem cell transplantation patient, parental nutrition should be reserved for those patients with the severe mucositis or ileus or intractable vomiting. Next. We have discussed this slide. Next, please. So, multimodal cancer treatment combines surgery, chemotherapy, radiotherapy, and this multiplies the nutrition risks. Therefore, the systemic anti-neoplastic agent have a characteristic toxicity limiting the dose and duration of therapy. Nutrition, specific nutrients, may improve the therapeutic index of the cancer treatment by increasing the efficacy, reducing the toxicity, or both. Next slide, please. So omega-3 fatty acid in the cancer, they inhibit the proteolysis induced factors or lipid mobilizing factor. They preserve and increase the lean body mass, decrease fatigue and improve quality of life, decreases inflammatory cytokine production, increase efficacy of chemoradiotherapy, reduces adverse effect of the chemoradiotherapy. So next slide, please. This has been discussed already. Move on to next slide, please. So, effect of the omega-3 fatty acid on the tumor cell response to the chemotherapy in patient with the breast carcinoma. This was the results were in the group of patient with the complete or the partial response level of 3 fatty acids were significantly higher versus the patient with the low response of the tumor progression. So, patient with increased plasma phospholipid DHA levels showed improved overall survival, longer time to progression. In addition, incidence of the chemotherapy related side effects was significantly lower. Next slide, please. So, effect of omega-3 fatty acid supplementation versus standard of care on the response rate and survival in non-small cell lung cancer patient on the palliative chemotherapy, and clearly shows that response and clinical benefit was more when the omega-3 fatty acids were used. Next slide, please. The conclusion was like omega-3 fatty acid, which are available in fish oil group, had a less GI symptoms, primarily diarrhea, and this group had a better performance scores. Next slide, please. Move on to next slide, please. We have discussed enough about the omega-3 fatty acid. Can move on to next slide, please. Next, please. These are the yes. So, goal of nutrition is again it is the to prevent and treat the malnutrition and cachexia, maintain improved muscle mass and function, improve the compliance with the anti-cancer therapies. This will ultimately reduce the side effect of the anti-cancer therapy, enhance efficacy of the multimodal therapies, and enhance the quality of life. Next slide, please. So we know that weight loss is associated with the reduced quality of life, and every effort should be made to maintain the weight during the cancer treatment. Next, please. Skip the slide, please. So these are the ESPN guidelines in the nutrition in the cancer patient, and they recommended that enteral nutrition, if oral nutrition remains inadequate despite nutritional intervention, then counseling, and parental nutrition if enteral nutrition is not sufficient or feasible. In suitable patient with the chronic insufficient dietary intake and or uncontrollable absorption, home artificial nutrition, either enteral or parental, is recommended. Next slides. So total energy expenditure of the cancer patient, if not measured individually, be assured to be similar to healthy subject, at least generally ranging from the 25 to 30 kilocalories per kg per day. Protein intake should be more than 1 gram per kg per day and preferably 1.5 gram per kg per day. If weight losing cancer patients with insulin resistance, then increased ratio of fat to carbohydrate calories, increase the energy density of the diet, and reduce the glycemic food. Vitamin and role of vitamin and trace elements, adequate amount of approximately equal to the recommended daily allowance, and discourage the use of high dose macronutrient in the absence of any specific deficiency. About the immunonutrients, omega-3 fatty acids, glutamine and arginine, they improve the lean body mass, reduces the infection complication, help in the wound healing, prevent or ameliorate the treatment related side effects like the diarrhea and mucositis. They restore the organ function and they improve the overall clinical outcomes. This is about the glutamine and omega-3 fatty acid. They hold the promise to prevent or treat the GI toxicity related to cancer chemotherapy. We have discussed in the earlier slide already. Next, please. So, parental nutrition is nowadays it is safer than ever before because this prevent the underfeeding but do not overfeed. Glycemic control is better, no longer hyper alimentation. Dual energy lipid plus glucose plus amino acids. Higher protein delivery closer to requirements, improve lipids, less pro-inflammatory, more immunomodulating, and benefit of parental nutrition in 3-chamber bags, clear understanding of enteral and parental complementarity. Next, please. So this is optimizing the parental nutrition delivery with all-in-one bag for administration of parental nutrition all-in-one. 3 bags like should be preferred instead of the multi-bottle system, and the use of standard commercially available parental nutrition may be considered in the ICU patient when the formulation meets the metabolic need of the patient. Next slide, please. So, coming to the take-home message for this presentation, that malnutrition in oncology practice is a very frequent problem. Oncology patients are very high risk of malnutrition and therefore increasing the risk of complications, length of hospital stay, and poor quality of life. Nutrition strategies modulate or reduce the cachexia, improve the quality of life, oncology treatment tolerance, and survival in the cancer, enhance effectiveness of multimodal therapy with immunomodulatory effect of the omega-3 fatty acids. I think we are done with the presentation. Thank you so much. Thank you all. If there are any questions related to nutrition, I'll be happy to discuss.
If there is no question, we conclude today's session. And thank you everyone for joining this webinar. Thank you. Good night.
Thank you so much, all the participants, and specifically very heartfelt thank to all the academic partners.
Thanks all, sir. Thanks to you also, sir, for explaining this.
Thank you. Specifically, I would like to
nutrition.
name each and everyone. Thank you, AstraZeneca, Fresenius Kabi, Roche, Lupin Oncology, Johnson Johnson, Dr. Reddy's, Glenmark, Pfizer, Datar Cancer Genetics, Sun, and Lost Intas Oncology. Thank you all the once again all the
Hello.
faculty, all the participants, and specifically
Hello.
thank to Cancer
Yes,
Strategic
please
for
tell me.
organizing such a wonderful event. Looking very warm good night to everyone,
जी.
and see you tomorrow at the same time.
सर मैं आपको बता दूंगा. सर मैं आपको बता दूंगा, मे बी वो राइट टाइम पे ही होगा.